Part 1 of the video demonstration describes the crucial role of endoscopic ultrasound in biliary pancreatitis. In acute biliary pancreatitis, appropriate indication and timing of endoscopic retrograde cholangiopancreatography (ERCP) is important to optimize outcome and to minimize complications. In patients with intermediate likelihood of common bile duct stones, endoscopic ultrasound (EUS) should be used to select patients for therapeutic ERCP. An EUS-guided approach will avoid unnecessary and potentially risky ERCP, as shown in this case of biliary pancreatitis. Radial EUS shows discrete exudation and edema of the papilla and the distal bile duct. As in the majority of patients, the causal small gallstone has already passed, and ERCP is superfluous. This is a very similar case of biliary pancreatitis. Using a longitudinal echoendoscope, edema of the papilla and of the distal bile duct wall is observed. Beyond any doubt, acute pancreatitis may be attributed to the spontaneous passage of a bile duct stone. Small stones may also be observed in non-dilated bile ducts. The hyperechoic reflex and the acoustic shadow are indicative of a biliary stone. In this case, the distal common bile duct stone is somewhat bigger. However, the stone has only a very weak shadow. EUS is as accurate as ERCP and magnetic resonance cholangiopancreatography (MRCP) in the detection of microlithiasis, with some advantage in the case of very small stones. In this case, a 4 mm stone is easily detected in a non-dilated distal bile duct. Biliary sludge and crystals are one important cause of acute biliary pancreatitis. As shown in this case, examined with a radial scanning echoendoscope, EUS is able to detect not only sludge within the enlarged gallbladder, but also within the common bile duct. Please pay attention to the finely dispersed and mobile echogenic reflexes within the non-dilated distal bile duct. This is a patient with a history of cholecystectomy who was examined due to a mild attack of acute pancreatitis. The common bile duct is visualized very well without any stone. However, hyperechoic material with shadowing is detected in the stump of the cystic duct and may be regarded as the cause of biliary pancreatitis. In conclusion, EUS is not necessary in patients with high likelihood of bile duct stones, cholangitis, or obstructive jaundice. In those patients, ERCP should be performed as soon as clinically required. However, for patients with intermediate likelihood of bile duct stones, EUS is an indispensable filtering method facilitating avoidance of ERCP and its associated risks in those cases in which bile duct stones can be excluded. However, if EUS examination detects stones, it is feasible to perform EUS and ERCP by the same endoscopist in one single session, or at least on the same day. Despite a detailed history, physical examination, routine laboratory testing, and abdominal imaging, the etiology is not established in up to 30% of patients with acute pancreatitis. In approximately 2/3 of patients with acute idiopathic pancreatitis, EUS will detect biliary stones or sludge, abnormalities of the pancreaticobiliary ductal system, pancreatic neoplasias, and early forms of chronic pancreatitis. One-third of cases of idiopathic acute pancreatitis turn out to be caused either by microlithiasis or sludge of the gallbladder, or by stones or sludge of the bile ducts. Even though transabdominal ultrasound is highly sensitive in diagnosing gallbladder stones, very small stones, less than 3 mm in diameter, and finely dispersed gallbladder sludge may be missed. In most cases, diagnosis is possible using radial or longitudinal scanning EUS. Besides, gallbladder bile duct deserves special attention. In this case of recurrent acute pancreatitis, 15 years after cholecystectomy, longitudinal EUS detects diminutive echogenic material in a normal-sized distal bile duct, which in ERCP turned out to be residual surgical suturing material. Sludge is a suspension of cholesterol crystals, mucin, glycoproteins, proteins, and debris that potentially leads to acute pancreatitis. There is no chance of diagnosing small amounts of sludge in the bile duct by transabdominal ultrasound or radiological imaging. Abnormalities of the pancreatic and biliary ducts are a less common cause of acute pancreatitis. This is an example of pancreas divisum. Radial EUS first shows major papilla, the normal bile duct, and a very small pancreatic duct. A few millimeters away, the slightly dilated dorsal pancreatic duct finds its way to the minor papilla. Ventral and dorsal pancreatic duct have no connection. This is a rare case of anomalous pancreaticobiliary junction combined with a choledochal cyst in a 27-year-old Asian woman with recurrent acute pancreatitis. Note the translucent non-shadowing stones within the cystic dilated bile duct. Despite a thorough search with the radial echo endoscope, a communication of the bile duct with the papilla is not found. However, only ERCP was able to prove the anomalous communication between pancreatic duct and bile duct. Pancreatic duct is cannulated and the guide wire glides into the choledochal cyst. Approximately 5% of all cases of idiopathic acute pancreatitis are caused by solid and cystic neoplasms of the ampulla or the pancreatic head. This female patient presents with mild acute pancreatitis. Longitudinal endosonography first demonstrates a dilated pancreatic duct with some non-shadowing echogenic material. There is neither a stricture nor a stone of the distal pancreatic duct. Conversely, the orifice of the pancreatic duct is widely open. Slow withdrawal of the scope along the pancreatic duct shows further non-shadowing material as well as papillary protrusions within the irregular dilated pancreatic duct. Endoscopically, mucus is shown to leave the papilla. This is a typical example of intraductal papillary mucinous neoplasia, IPMN, of the main duct type. 15 to 30% of all IPMN cases present with acute pancreatitis. Branch duct type IPMN is more frequent than the main duct type. Originating in the side branches of the pancreatic ductal system, 70% of branch duct IPMN are located in the pancreatic head and have a grape-like appearance, as in this case. Acute pancreatitis is induced by transient mucus obstruction of the pancreatic ducts. In this case of branch duct IPMN with acute pancreatitis, ductal communication as well as mucus within the cysts are very recognizable. Arrowheads indicate ductal communications, and the arrow points to intracystic mucus. In this 68-year-old lady with recurrent acute pancreatitis, an 8 mm hypoechoic seemingly solid lesion is visible in close contact to the main pancreatic duct. EUS-guided fine needle aspiration reveals IPMN of the gastric type. The solid appearance is simulated by hypoechoic mucus, which has caused the recurrent attacks of pancreatitis. The arrow points to the communication of the ventral and dorsal pancreatic ducts. Solid pancreatic tumors rarely induce acute pancreatitis. In this case of a 50-year-old female patient with recurrent acute attacks of pancreatitis, chronic alcoholic pancreatitis was initially assumed. Longitudinal EUS shows peripancreatic exudation, ductal dilatation, irregular lobulation, and hyperechoic reflexes of the pancreatic parenchyma, consistent with an acute attack of chronic pancreatitis. However, further findings question this assumption. Marked dilatation of the common bile duct, as well as of the pancreatic duct, is apparently not caused by fibrosis or calcification within the pancreatic head, but by a hypoechoic tumor in the ampullary region. Contrast-enhanced EUS demonstrates hypovascularity of the tumor. Diagnosis is made of an ampullary cancer with obstructive chronic pancreatitis with recurrent acute attacks, and surgical treatment is decided. Clinical differentiation between recurrent attacks of acute pancreatitis and early chronic pancreatitis is difficult. Therefore, in around 20% of cases of idiopathic acute pancreatitis, finally a diagnosis of chronic pancreatitis is made. This is the interesting case of a 42-year-old female patient who has experienced 3 acute pancreatitis attacks. Radiological imaging showed a normal pancreas. Longitudinal EUS demonstrates a homogeneous pancreatic parenchyma. However, shadowing stones are easily detected within the slightly dilated pancreatic duct. No other criteria of chronic pancreatitis or ductal abnormalities are detected. Detailed history and laboratory diagnostics, including genetic test, in this particular case did not reveal the cause of chronic pancreatitis. This is a very similar case of idiopathic pancreaticolithiasis causing recurrent acute pancreatitis. The 32-year-old female patient credibly denied moderate or heavy alcohol intake, and detailed history and results of laboratory testing did not reveal any of the established causes of pancreatitis. Radial endosonography shows a somewhat inhomogeneous pancreatic tail and body with a hypoechoic rim. The pancreatic duct is slightly dilated, and surprisingly a solitary small pancreatic duct stone is observed. However, in contrast to these two cases, in most cases of recurrent acute pancreatitis, with endosonographic features of chronic pancreatitis detailed and repeated history reveals relevant alcohol intake, as in this case of a 57-year-old male patient. We find typical diagnostic criteria of early chronic alcoholic pancreatitis, a honeycomb appearance of pancreatic parenchyma, hyperechoic stranding, and non-shadowing echogenic spots, and a slightly dilated and irregular pancreatic duct. In conclusion, in approximately 2/3 of patients with idiopathic acute pancreatitis, careful endosonographic examination will reveal the etiology of acute pancreatitis. Biliary stone disease and sludge have been shown in several studies to be the most common causes of idiopathic pancreatitis. Meticulous visualization of the pancreatic and biliary ductal systems will reveal pancreas divisum and other ductal abnormalities in up to 7% of cases. For the detection of ductal anomalies, MRCP and ERCP are superior to EUS. Intraductal papillary mucinous neoplasias and rarely solid pancreatic tumors are considered to be causes of acute pancreatitis in up to 9% of cases. Primarily due to different inclusion criteria in endosonographic studies on the etiology of acute idiopathic pancreatitis, the frequency of chronic pancreatitis varies widely between 2% and 32%. Part 3 of the video demonstration describes typical EUS features and complications of acute pancreatitis. EUS may give valuable information not only on the etiology but also on the severity of acute pancreatitis. The typical ultrasonographic features of acute pancreatitis, like focal or diffuse edema, effusion, and fluid collections, may be detected very early by EUS. Moreover, EUS may be used as a complementary tool to detect complications of acute pancreatitis, like parenchymal necrosis, pancreatic abscess, biliary obstruction, venous thrombosis, and arterial pseudoaneurysm. This is a typical example of the endosonographic appearance of the pancreatic gland in mild pancreatitis. There is some peripancreatic fluid, and, due to edema, the pancreatic parenchyma is swollen and somewhat heterogeneous. Neighboring vessels are not affected. In this case, focal pancreatic edema is very pronounced. The pancreatic head is swollen and heterogeneous. In particular, irregularly shaped hypoechoic parenchymal areas are found in the pancreatic neck. Real-time elastography impressively shows heterogeneous stiffness of the affected parenchyma. This is another patient with mild acute pancreatitis. Diffuse hypoechoic edema of the pancreatic body and tail is visualized, and the pancreatic capsule is accentuated by a hypoechoic rim. In this case of acute biliary pancreatitis, radial scanning endosonography reveals peripancreatic effusions. This is a male patient with severe biliary pancreatitis. Hypoechoic lymph nodes are shown in the vicinity of the ill-defined pancreatic gland. We find confluent areas of hypoechoic peripancreatic fluid as well as hypoechoic areas in the pancreatic head and body. Near the papilla, the pancreatic head is compressed by edema and inflammation. In this case of acute pancreatitis of unknown etiology, a bile duct stone can be ruled out with longitudinal endosonography, and the lumen of the lumen is compressed due to inflammation of the pancreatic head parenchyma. Following stepwise withdrawal of the scope, extensive peripancreatic effusions are visualized. Parenchymal necrosis is a marker of worse prognosis of acute pancreatitis. In this case of severe acute pancreatitis, the patient suffers from abdominal pain, fever, and renal insufficiency. EUS visualizes confluent areas of necrosis with the pancreatic head, swelling of the duodenal wall, and compression of the bile duct. Endoscopic ultrasound has an accepted role for diagnosis, treatment, and follow-up of peripancreatic fluid collections. This is a typical example of a pancreatic head pseudocyst. The lumen of the pseudocyst is anechoic, but there is also some hypoechoic debris within the pseudocyst. A second small pseudocyst is found near the thickened and hypervascular duodenal wall. The common bile duct is dilated. In addition to clinical deterioration, a heterogeneous fluctuating content of a fluid collection is an important diagnostic sign of pancreatic abscess. A typical feature of an abscess is the hypervascular rim around the anechoic fluid collection, as shown by contrast-enhanced EUS. As a consequence of acute pancreatitis, vascular complications occur in up to 25% of cases. This is a very impressive case of portal vein thrombosis complicating acute alcoholic pancreatitis in a 54-year-old male patient. The transducer of the longitudinal scanning echo endoscope is directed to the liver hilum, and echogenic material is visualized within the dilated portal vein. Color-coded duplex scanning demonstrates blood flow around the thrombotic material and within the hepatic artery. As clearly can be seen, the thrombosis extends into the intrahepatic branches. As a consequence of portal or splenic vein thrombosis, segmental portal hypertension develops. In this case of a patient with acute alcoholic pancreatitis, longitudinal EUS reveals small-sized gastric wall varices starting from the splenic vein near the splenic hilum. At the level of the pancreatic tail, there is flow detectable in the splenic artery, but not within the hypoechoic lumen of the splenic vein, which is included in the hypoechoic inflammatory process of the pancreatic tail region. In this case, gastric varices originating from large-sized perigastric collaterals are visualized between gastric fundus and splenic hilum. The patient was admitted to hospital only 2 weeks before due to a first attack of severe alcoholic pancreatitis. Again, the splenic vein is completely occluded by a hypoechoic inflammatory pseudotumor of the pancreatic tail. Flow can only be detected in the splenic artery. Positive identification of the splenic vein is not possible. Portovenous collaterals within the pancreatic gland are a possible late consequence of splenic and portal thrombosis, as shown in this video sequence. Pseudoaneurysms of the visceral arteries develop as a consequence of tryptic degeneration of the arterial wall in acute pancreatitis. This is an impressive example of a very small pseudoaneurysm of the splenic artery with a small pancreatic pseudocyst. Summarizing the role of endoscopic ultrasound in acute pancreatitis, two main indications are established. 1. EUS should be performed when a biliary cause is suspected and the probability of a common bile duct stone is intermediate. In this clinical situation, EUS reliably selects patients for therapeutic ERCP. 2. EUS should be used to establish the etiology of acute pancreatitis when thorough history, careful clinical examination, and abdominal imaging fail to do so. The diagnostic yield of EUS in this indication is as high as 65%. Radial and longitudinal scanning echoendoscopes are both suitable to perform EUS in these indications. The endosonographer should pay attention to the gallbladder and the bile duct to detect stones and sludge, as well as to the pancreatic duct to detect pancreatic divisum, other abnormalities of the pancreaticobiliary ducts, and intraductal papillary mucinous neoplasias. Careful examination of the whole pancreatic gland is necessary to visualize features of chronic pancreatitis or solid pancreatic tumors. Complementary to transabdominal ultrasound and computed tomography, EUS may play a valuable role in the assessment of the typical features and complications of acute pancreatitis.